I'm honored to be given the opportunity of speaking to this group of distinguished clinicians and scientists. I can tell by a lot of names that I see on the screen there. I hope I won't be boring you with this stuff. And if Melissa agrees, I will start sharing my screen. Is that the time to do it, Melissa?
Yes, it's your turn.
That's it. Can you confirm that you see it?
It looks great.
Right. So I have no conflicts of interest whatsoever. In fact, I'm always quite a bit at conflict with pharmaceutical industries. I would like to dedicate the slides I'll be showing, some of which are also very old, to the many mentors, teachers, and friends who have invested time and energy trying to understand the genetic disorders and share their results, but especially to the patients and their families who gift us with their trust in us. They allow us to learn from their destiny, their life experiences, their sufferings, ultimately. They allow us to show and sometimes even publish their photographs. And by the way, they teach us about what really matters in life. So it's really for them that we do all this. I have thought of giving you, the older I get, the more I like to give a historical perspective on the recognition of genetic disorders of bone in the context of clinical and molecular genetics. Then the main first part will be on the 2023 revision on the nosology, the changes that we have made there. It's mainly the naming system that has changed. Then I will switch to a second part that also elicits memories, because OI is something I have been studying quite at the beginning of my times in the lab and in the clinic. And OI does have quite a special role in clinical genetics, in human genetics, I would say, while it has become a sort of headache in the nosology. And you will see why. We have problems with the naming of the brittle bone conditions, and we'll see how to try to solve that. And then I will give some perspectives, and I'm very happy to hear that you will be speaking about registries, because that's one of the things that is very important too. This slide is way too long for you to read in its entirety. It's some milestones in genetics, in inborn errors of metabolism, and in disorders of connective tissue and bone. If you see up here on the right, there's Osteogenesis Imperfecta. Everything starts there, doesn't it? There's achondroplasia. There are molecular concepts like sickle cell anemia. There's hypophosphatasia here. And then at relatively down low, there's the explosion of clinical genetics, starting with the chromosome bank. You know that in 2 years, all the major chromosomal abnormalities have been described: trisomy 21, Turner, Klinefelter, 13, 18, and even the Philadelphia chromosomes. And that rang in the 60s. That's when clinical genetics really exploded. So let me do a little diversion. Studying genetic disease is the privilege of having defeated infections and nutritional disorders. Cod liver oil was rediscovered in the mid-19th century, but widely used only in the 30s and 40s. And there is this lady, Sister Mary, who wrote up a history of rickets. And this just goes to show how the numbers went down dramatically, and luckily, over the first and second part of the 20th century. And it's in 1948, down here, that Rathbun at Toronto Sick Kids described hypophosphatasia as a new developmental anomaly. I think this is quite important. These years have brought a lot of discoveries. 1 year later, Linus Paulding and Harvey Itano wrote about a molecular disease. Now, this was really a new concept that a human being might be sick, not because of something infectious or because he lacked something, but there was something wrong with the molecule. And this is, I think, quite fundamental. And to go back to what's going on here, this is not going on. Let me click. Okay. This was sometime later the discovery of a homozygous biallelic variant in the gene of liver, bone, kidney. At that time, it was called like that, alkaline phosphatase, giving hypophosphatasia. And I think, do I see Cheryl Greenberg there in the audience?
Yeah, I'm here.
Well, you know, I dotted you yellow there before knowing that you were around, because I think it's actually your work there. You were the first to treat these kids, as far as I remember. And it's taken a lot of years from the enzyme abnormality to the molecular defect to the enzyme treatment that works actually quite well. This is a wonderful paradigm. Unfortunately, it's not as nice with many other diseases. Osteogenesis imperfecta and the pain in the neck, we still don't have a good therapy there. But this is just to show a perspective over the years of a disease that's recognized, understood, and finally a cure is found. If we go back here on the right, we see the birth defect conferences begin in 1968, and in 1970 there is the first, not nosology at the time, but nomenclature. This is the fourth volume in the original article series of the birth defects conferences, the one on the skeletal dysplasias. It's full of interesting descriptions. Everything, or a lot of things, were new at that time. And these are the people who were involved there. And recently, a lot of colleagues have helped me to identify them. We won't lose time here, but we see Victor McCusick, Dave Riemoin, John Opitz, Jürgen Spranger, Judy Hall, John Dorser, radiologist, Hans Zellweger, a lot of famous people. They were all together there, and they gave a very big impulse to the study of genetic disorders of bone. It's also in that book that we find twice the concept of nosology. This is Jürgen Spranger writing on the nosology of lysosomal storage disorders. Long story short, in 1970, there was the first conference for the compilation of this nomenclature. At that time, it was simply to call the things with a good name, just giving the right name to things so that everybody could understand what they were speaking about. Then many other editions have followed. You see them here on the list. And recently, the 2023 revision has come out, and that's where we will spend a little bit of time on. I'll show you some historical pictures. This is 91. In Germany, actually, you see here people that you may know: David Silence, Ralph Lachman, Poznanski, Andres Gideon, Dave Riemann, Bob Gorlin, Bill Horton, Judy Hall, and so on. The ISDS, the International Skeletal Dysplasia Society, was established in 1999. And then it was like the nosology group that was completely unformal before, was actually mandated by the International Skeletal Dysplasia Society to have a permanent group to follow up on this nosology. There was a rejuvenation in 2019, which was very, very useful. This was 1999, the Constitution. You see people that were a bit younger there. This is 2001. This is not really important. This is 2005. And we come back to 2023. The nosology is online and completely freely downloadable. There is even a table. If you have to use it to send to your lab or do anything with it, you can simply download the table from the website at isds.ch. We are today at 774 different entries, 41 groups, 552 different genes, which is actually quite mind-blowing. The main difference to the previous version is the adoption of the dyadic naming system. That is, the condition and the gene changes in which give rise to that conditions. Just two examples, SMED with joint laxity, comma, exo-C6B related. You can switch them around and say exo-C6B related SEMD with joint laxity. Or bone fragility with calvarial donut lesions, that's a very bizarre disorder, SGSM2 related. Why did we do this? There's many reasons, and I'll be really happy to have your opinion and discuss it with you. First, the group wanted to stop the proliferation of numbered lists with no inherent information. Those of you who do clinical genetics may know that there are so many ataxias or spasticity forms. There's over 100 of them. And every time you have to go up, if they give you the number, you have to go to OMIM, look up the number and find out which gene it relates to. So the number is really not useful. Also, it was to disambiguate between conditions with the same name but different genes, like osteogenesis, just to name one. Type 1, type 2, type 3. It's 3 different genes. So rather saying type 1, type 2, type 3, give directly the gene. It's much more practical, especially if you have to collaborate with laboratories, be it for diagnosis or be it for research. The lab doesn't really care what the clinicians think is type 1 or type 2. They're much happier to go directly to the gene so they can sequence that or look at that and so on. There is, luckily, in my opinion, a general trend toward the adoption of a dyadic system, like Gene Reviews is also adopting it. So the nosology, there's a typo there, exists in a whole ecosystem of catalogs and classification. First of all, let's mention Orphanet. We have tried to obtain some synchronization with Orphanet, but Orphanet is really rather anarchic. There is no principle governing whether a condition is in Orphanet or not. So everything is in there. It's a bit acritical. Then there is, of course, the McCusey catalog, MIM or OMIM, and that nobody will ever put any doubt on this. It remains the cardinal reference system in clinical practice for most of us. And indeed, there are excellent relationships between the OMIM team and the nosology experts. Many of us remember when Victor McCusey came to Europe in the early 80s with the big computers and big printers and set up the system. And we have been trying to work together as well as possible. And the nosology has as many links as possible to OMIM. You can see them all on the website. However, the maintenance of OMIM is an incredibly laborious, Herculean task, and it's done by a small team. It's mainly Joanna Emberger, who was there ages ago. Then it's Ada Hamosh, who was taken over later when Victor stopped doing that. And it's a lot of work. And when they click at the beginning, when you go on OMIM, they want your support. I think they really need it and deserve it. It's a bit of a pity then that they don't get it. Anyway, the OMIM catalog tends to grow appositionally, and what they are probably unable to do, and I think Ada Hamosh doesn't want to do it, is to prune certain things and reshape them. They want to keep the historicity, if you want to, but they're not ready to take out disorders and say, no, this has become this other disorder, and so on. This is one thing. The other thing is that because they are in OMIM and they can type in what they want, they like to coin new eponyms. Like Ada and the team like to make eponyms, abbreviations, or whatever. And more often than not, they are not good because they just read the paper relatively quickly. They take the symptoms and they coin something, but they don't have the time to go into the history and whatever. So I think it's true what has been decided, getting rid of the eponyms and just putting the gene name will be much better. And I think OMIM will eventually have to adopt the dyadic naming system. Now, if you've read the correspondence between Les Biesecker and Ada Hamosh in the American Journal of Human, it's been quite hot. Ada was not really happy that Les suggested that they adopt it, but I think it's in the nature of things. In the end, the dyadic system is much better, has many advantages, and I think OMIM should adopt it. Now, in the ecosystem, the nosology for bone disorders has been there for a long time. But then we have become aware through Carlos Ferreira, whom you see here teaching at our course in Lausanne. Carlos is a very smart person, and he plays for both teams. He plays for the skeletal team, but he also likes inborn errors of metabolism. And he was a little bit inspired by the bone disorders nosology, and he actually stimulated with excellent colleagues, as you can see in the paper, and nosology for the inborn errors of metabolism. So Carlos makes a little bit of the bridge between these two worlds, and it's actually quite interesting. Now, the inborn errors of metabolism nosology appeared in 2018 for the first time. There has been already 2 revisions. Carlos, I think, is here, and he can correct me. And they, in their first edition, they already have more disorders than we bone people have. So you see, it's very good that these nosologies are done, because the number of disorders is getting so large that you really need a paper to keep them a little bit ordered in your brain, like Dr. Tosi said, to get the brain straight on what these disorders are. Now, there is much overlap with the skeletal nosology, because a lot of skeletal disorders are metabolic in nature. But one thing is different in the metabolic nosology, and you see it circled in red here. Severity alone is not considered sufficient for separation into different entries when a single or the same gene product is involved. Now, this is quite important for us in the skeletal nosology. It's not like that. If we take, for example, collagen 2, it's true that the mild Stickler syndrome, which is haploinsufficiency, has a completely different appearance and a completely different prognosis than, say, achondrogenesis type 2. So because they are visually so different and their prognosis is so different, the skeletal people that came from the morphologic point had them as different disorders, and so far they have stayed different disorders. Just imagine osteogenesis imperfecta. It's exactly the same. From collagen 1, you can have everything. From the completely lethal, from the very severe fetus to the mild type 1 in an individual who may not even know that he has mild osteogenesis imperfecta. So this is a big difference, but this is something that we will have to keep in mind. Are we going to continue splitting the disorders and giving them different names? Or are we going to try and lump them to a certain degree? So the 2023 nosology has 41 groups. Colored in blue here are those that have been rearranged a little bit. That is not so important. The important thing to say is that we are still using a combination of criteria. So some groups are defined just by a gene. The FGFR3 group is just the gene-defined group. Collagen 2, same thing. Some are defined by a pathway, like PTH, parathyroid hormone, and its pathway, receptors, like peptides, and so on. Some are biochemistry, and we'll see, for example, the sulfation group. But then there are other groups that are so heterogeneous that are still defined only by radiographic features, like metaphyseal, spondylometaphyseal, sclerosing, or osteopetrosis. Some others are defined clinically. Dysplasias with multiple dislocation. That's a clinical feature. And then the last groups, those that comprise the dysostosis, are actually defined anatomically. Dysostosis of the skull, the face, the clavicle, the vertebrae, the limbs, and so on. So it remains very heterogeneous. And this is one of the main criticisms that people do. Now, is it a genetic classification? Is it a pathway or whatever? For some groups, we can afford to go molecular only. For others, it's just as it is, clinical, radiographic, and so on. One group, of course, that you may be interested in is defined by the propensity to fractures, osteogenesis imperfecta, and bone fragility disorders. The classification system is thus far from perfect. Biology has more fantasy than our stiff classification may capture. It's important to be aware of that. So let's go through some examples. This is the one gene, one group disorders. We mentioned a group, sorry. It's collagen 2, the heterogeneity you know very well, achondrogenesis, 2 Stickler, 2 proximal femoral epiphysis dysplasia, and all the variants, Kniest, spondyloperipheral, metatarsal shortening, Torrance, you take it all. It's so fantastic that this molecule can give rise to so many variants. Is it justified to give each one a specific label? I'm not going to discuss it. So far, it is like that. Let's see whether we find something better. Another group is defined by something biochemical. This is the sulfation disorders. You see the first 4 are disorders in the sulfate transporter, SAL26A2 or diastrophic dysplasia sulfate transporter. You see a little bit of the clinic here, how heterogeneous it can be. The others are actually either generation of biologically active sulfate or sulfotransferases. In the future, this group may possibly be joined to the multiple dislocation group. That's a clinically defined group, as you see here. But 7 of 9 genes in this group are enzyme of transporters related to glycosaminoglycan synthesis. So glycosaminoglycans are synthesized and then sulfated. So it's a logical extension to have these 2 groups perhaps one day come together because the phenotypes can also be quite similar. We have spoken a little moment of sulfotransferases. Now, the opposite, the catabolic, that's lysosomal. These are all the sulfatases. And it's exactly the same steps on the other way. They give rise to the mucopolysaccharidosis and to the other lysosomal storage disorders. Many of them, or most of them, have some skeletal features. It's interesting that this group has been static for many years, but this in 2023 we have 2 new disorders, aryl sulfatase K and a form of mucolipidosis. I can hear someone in the background, no problem.
Someone needs to mute, please. Thank you.
This is another group that I'll show some examples. This is a group that has absolutely almost nothing in common in way of pathogenesis. This is a group purely defined by some radiographic features, spondylometaphyseal or spondyloepimetaphyseal. The key to understanding this is the pleiotropism of many genes. They touch the eye, the brain, the liver, the immune system, sometimes the heart and the skeleton. So you will find them in the skeletal disorders, even if their clinical features are quite various and they touch many other organs or systems. And actually, this is interesting because skeletal disorders, after 30 years or so, have become fashionable. You will have difficulty in finding a newly defined genetic disorders where the authors don't try to do, oh, there's also some skeletal features. Even if there is a crooked fifth finger, they say developmental delay, whatever, microcephaly, and skeletal features. So it's interesting. The skeleton participates in many pathogenetic processes. Just some examples, you don't have to remember them at all. This is spondylochondrogen dysplasia, that is bone, immune dysregulation, brain calcification, and spasticity. And the gene is a very important gene, is a lysosomal acid phosphatase. There is Jose Milan there, whom we discussed it ages ago. Phosphatases are very important. Another one, this is actually quite new, is the phosphatidylserine decarboxylase deficiency that gives what we call the Lieberfarb syndrome, retinal degeneration, bone dysplasia with joint laxity, hypoacusis, and microcephaly. So quite another pleiotropic gene. The last one is sialic acid synthesis disorder. It's again bone, brain, platelets, other organs, and of course, short stature. And this is a sialic acid deficiency disorder, which we were hoping could be treatable, but it looks like even if you come too late and give these people sialic acid, it does not really improve them because the sialic acid is excreted very rapidly in the urine. Oh, here's another one. This is another enzyme. This makes, again, eye, bone, intellectual disability. And this is another enzyme, nicotinamide nucleotide adenylyl transferase, NMNAT. Metabolic disorders in principle could be amenable to treatment, but it's not easy. In no case has there been an easy way to treat or help these patients by treating them. The last but one group I would like to show you is the groups with dysostosis. These are the blueprint disorders, nothing to do with metabolism, nothing to do with bone homeostasis. You see them down here. These are cleidocranial dysplasia, craniosynostosis, craniofacial, vertebral, coster, patella, reduction defects, and all that. Nothing metabolic. This is the blueprints. It's the embryonic processes. This is an example, the TBX15 related cousin syndrome, quite a severe skeletal malformation, if you want to. This lady has an academic degree and writes poetry. This is another recent example. This is an example, a disorder that exists in two forms. One is the limbs and brain type, related to the ingrained 1 gene, is this little girl here, who has complete absence of the cerebellum. It's very severe neurologic disorder, plus limb malformations. But you can also have a recessive loss of this link RNA, 200,000 bases away from the gene. And this gives you a limbs-only phenotype that you see in this young boy here, who has the same limb deformations or malformations than this girl, but is completely intelligent. His brain is completely normal. This is a nice example of a little genetic system, and the defects are depending on where the variant is. Now let's come to the group that may perhaps be so important to you, which is osteogenesis imperfecta and bone fragility. And this disorder, this group is actually a headache because there's so many disorders there. We have a little problem, I think. There's 36 genes giving 55 disorders. Now, there's two factors here. First of all, osteogenesis imperfecta, bone is so important that you can touch any of many mechanisms, and you have a bone fragility disorder. That's uncontested. But there is also the problem that we have not been able in this nosology to get rid of the Sillence system, of the Sillence classification 1, 4, 3, 2. And so there are all these genes compounded with 3 or 4 Sillence variants that give this incredible array of disorders, which is a little bit too much. And switching to a purely dyadic naming system may be an advantage here. So I'll switch to the second part of the talk. I'll be quick. That concerns osteogenesis imperfecta. Now, probably you know more about me, so please be patient if I say things that you already know. Of course, everybody should know that the name osteogenesis imperfecta was coined by Willem Vrolijk, a pathologist, almost as a byproduct. In the Dutch version of his paper, he said gebrekkige beenvorming, which means breakable bone formation. You can almost read it in Dutch. But then there was a table. In the same paper, there was a table with the Latin names. And for the Latin, he chose the name Osteogenesis imperfecta. And that name stuck. You can follow the bit of the story of osteogenesis imperfecta in the McCusick books, Hereditary Disorders of Connective Tissue. And here is David Salance, whom I think you all at least know by name. Osteogenesis imperfecta has always been there, and you find a lot of papers. But the papers never tried to make a sense of the clinical heterogeneity. Now, osteogenesis imperfecta, there's so many clinical variants. Now, David Salance did the job and tried to say, if we call this osteogenesis imperfecta, let's try to make some order and to see different types. And he thought that the different types also would have different inheritance patterns. Namely, the 1, 3, and 4, the 1 is the milder, the 4th is the second more severe, the 3 is severe, and the 2 is lethal. And he said, I think the 2, the lethal, is recessive. But this is an old McCusick thing. Victor had written, oh, if disorders exist in more than one form, the recessive form tends to be more severe than the dominant form. And David just picked this up, and this is what he wrote. Today, it's easy for us to correct, but at the time, it was fundamental. It made a big bang, and his classification was widely adopted. Still today, we speak of Y type 1, Y type 2, and so on. David is a big splitter. So in 1984, he comes and tries to split lethal Y type 2 in 3 types. Here it is, a paper in American Journal of Medical in 1984. But then Jürgen Spranger comes up, and Jürgen is a notorious lumper. And he said, the proof of their difference probably needs the help of the biochemist. For even the most astute observations, such as those by David Salance and his associate, will come to their limits. This is an editorial just after the Salance paper. And if you are not familiar with splitters and lumpers, this is a Victor McCusick cartoon. The lumper just brings different bones and lumps them, while he says the cartoons indicate that splitting is much harder work than lumping. So Victor McCusick was a splitter, of course, and he made a catalog of all these diseases. So this is Keiko Ramirez here, seen at a conference room that we shared. And Keiko Ramirez was a molecular biologist from Italy, and he went to the United States, and he played with the collagen genes, and he was the first to clone the collagen genes. And in 1983, thanks to his cloning of the gene, it was detected that cells from a fetus with lethal osteogenesis imperfecta had a deletion in the collagen 1 alpha 1 gene. And so this was the paper in Nature, and Darwin Prokop, that at the time was the leading scientist in the collagen field, wrote this little editorial also, phenotypic heterogeneity, protein suicide, and long and short and long collagens, because the cells that produce the short and the long collagens, eventually the short collagens made protein suicide because it perturbed also the long collagen that was there. To make a long story short. 1 year later, actually it was about the same time, Beat Steinmann in Zurich came to study cells and also the bone from this little baby who was born and did not survive. He was born in eastern Switzerland. You can notice here that his arm was torn during delivery. Osteogenesis imperfecta is a connective tissue disorder, not only a bone disorder. And he found that the genes were normally long, the collagens were normally long in the cells of this baby, but there was a glycine to cysteine substitution in the triple helical domain. So the collagen helix form was formed much more slowly and was quite unstable. So this is his biochemistry paper, JBC 1984, that fulfilled a prediction of McKusick. Victor had written, I hope you can read it here, yes. Do the amino acid sequences of collagen in OI differ from those in the normal by a single amino acid substitution, comparable to the differences demonstrated in many hemoglobin variants? So this was the proof, yes, indeed. And this was Dan Cohn in Peter Byers' lab, I'm sure you know them all, found that it was indeed a single nucleotide change in the COL1A1 gene. Please note well, at the heterozygous state. So this is an incredible milestone, because it's like saying, take your DNA or mine, change one nucleotide in a heterozygous state, and you have a lethal phenotype. I think there is no stronger proof of the power of genetics, if you want to. So why does this not go on? So this was an incredibly powerful discovery. And indeed, the concept of glycine substitutions in the collagen helix really became very, very important and dominated the whole research field, at least for a couple of years. They gave origin to the dominant negative versus the haploinsufficiency. They gave rise to the molecular topology concept, where a change occurs in the molecule also influences the phenotype. And most importantly, it applies almost identically to collagen 2 in cartilage and to collagen 3 that gives rise to the lethal vascular Ehlers-Danlos type 4 syndrome. So incredibly important step. Now, Silence, David, had seen multiple affected sibs with lethal OI born to unaffected parents. Was the inheritance really recessive? Maybe not. It was, again, Dan Cohn here with Peter Byers that demonstrated for the first time gonadal mosaicism actually in men. This gentleman here had two affected babies with different partners, and he could show that there was a glycine substitution caused by a single nucleotide substitution in the collagen 1 alpha 1 gene, and that the variant, the father was phenotypically normal, but his spermatocytes, there was a little proportion of them that had this variant. So this was a demonstration of germinal gonadal mosaicism, and it's explained perhaps part of the families of recurrent osteogenesis imperfecta with normal parents. So was David Silence completely wrong? Is there no such thing like recessive osteogenesis imperfecta? For a couple of years, it looked like it could be that way. Well, it was not. So this is Dan Cohn here. This is Peter Byers in 1997 in Marina del Rey. And we will also switch to see Matt Warman here. He can't be on the talk today. He wrote me because he's traveling. And this is Peter Byton. You see him here on the right. Peter, unfortunately, deceased some months ago. Now, Peter was a big splitter. You can also think of the Ehlers-Danlos. He was the first one. He did with Ehlers-Danlos syndrome what David Silence did to OI, Peter did earlier, 68, to Ehlers-Danlos, type 1, type 2, type 3 hypermobile, type 4, the vascular one, and the others. And you see him here, very happy. Peter was a very happy person. And Peter published a paper in 1985, so we're still in the 80s, about the ocular form of osteogenesis imperfecta. He wrote a new autosomal recessive syndrome. But he was wrong, because, as some people found out, this was not a new form. It was a form that had been already described in the 60s. The osteoporosis pseudoglioma syndrome was described in the blue book that I showed you, the Skeletal Dysplasia Conference. And so this family here that was published there by some young guy there also showed that heterozygotes probably had some effect of being heterozygous, suggested an effect of the mutant gene also in the heterozygous state. And indeed, Matt Warman and his lab, some years later, found the gene for this, and it is LRP5. And this has also been an incredibly important paper. It's one of the most cited paper ever in the bone literature. Matt and Yaojin Gong showed that variants in LRP5, recessive, biallelic, do the osteoporosis pseudoglioma. This is a Swiss patient. But monoallelic heterozygous carriers also have reduced bone mass and osteoporosis. First. Second, the Wnt signaling pathway is today well known as one of the most important pathways in bone homeostasis. And this was the first paper that actually pinpointed one player in this pathway as important in osteogenesis imperfecta. Now, to make a long story short, Silence was, of course, right. There are many, many, many forms of recessive osteogenesis imperfecta. And I have not listed them all here. I just put on some examples for you to see. This is recessive OI with pterygia, Brooke syndrome. This is lysyl hydroxylase 2. This is Fleur van Dijk, who is another OI expert. She discovered cyclophilin B mutation. I think the gene has another name today, seen here at our course in 2009. Peter Byers, again, his lab found a very rare SERPIN-H variant. Deb Krakow in Los Angeles and Yasmin Alanay from Turkey, but in Los Angeles, found out about FKBP10. And this was a particular group of patients because they actually have an allele that on the same allele very close are an FKBP10 recessive variant and a keratin 14. So they thought it was a new syndrome, but it's actually a combination of two distinct disorders, osteogenesis imperfecta and epidermolysis bullosa. Quite difficult to find that out. And another disorder I'll just speak about in a couple of minutes is pile disease. Now, pile disease is a tall stature condition, but the bones are really fragile. And this has been well described in the 30s when the condition was named. Edwin Pyle wrote, the periosteum, the fibrous tissue was normal, but the bone beneath it was very soft, so that the chisel could be forced through the bone almost without the use of a mallet. And Max Cohn in Germany, 2 years later, same disease. The cortical bone was so thin that it could be pressed in like paper. So it's clearly a bone fragility disorder, but it's not a collagen disorder. It's something completely different. And this is Pelin Kieper-Simkimsek, who found the family that we studied. And this is Roland Barron, who you must know, and Francesca Gori, who did the biochemistry, the bone biology part of it. We found the gene in between. And they found that this disease is called by biallelic recessive SFRP4 variants. And when you don't have this SFRP4, the newly deposited spongy bone is not converted to cortical bone. So if you have no SFRP4, they found you have too much sclerostin and you make no cortex. Sclerostin has its name from another disorder called sclerosteosis. And if you don't have sclerostin, you make a hyperostosis. So sclerostin seems to be regulated by SFRP4 and by other genes, but seems to be a key player in favoring or blocking the formation of cortical bone. Of course, everybody thought when we published it years ago that anti-sclerostin antibodies would be a good approach for osteogenesis imperfecta, because you must have before your eyes how in severe OI, often you don't have a cortex. Unfortunately, as far as I have learned, I have not been involved myself, but the anti-sclerostin antibodies do have some severe side effects. So there is no breakthrough there yet, but I think that it remains a very hard thing to do. So summary and conclusions on osteogenesis imperfecta. You cannot conclude that OI is really a never-ending story. Many conditions with bone fragility are not called osteogenesis imperfecta, but are just as interesting. Now, your mileage may vary, but I like to think roughly 90% of cases are collagen 1 mutations in the two genes, collagen 1A1, collagen 1A2. It may be 85%, I don't know, but it's not much less than that. The other cases may be either pseudo-recessive with parental mosaicism in the collagen genes, or indeed one of these many true recessives, and the list is getting longer. There are other dominants like osteogenesis imperfecta type 5 with EFITM, the EFITM gene. It's all extremely interesting. David was not wrong after all. There are recessive forms, and what all these forms have taught us is that the biology of bone is incredibly complex and incredibly interesting. What is relevant, though, is that the specific genetics in an individual or a family is needed to give genetic counseling. And what is also relevant is that the pathogenetic mechanism is the only way to design therapeutic approaches. That's why it's so important to go on studying them. Now, back to the classification and naming. All of you that have done NGS have been surprised by the findings that some disorders, some individuals have variants in the gene that you would not have expected to be there. So the rule is clinical variability is really the rule. We know today that with the exception of achondroplasia with the FGFR3, it's always the same variant. But I mean, most other genes, the clinical variability, the clinical spectrum is the rule. So we may be moving on from the old classification and naming of the different conditions to the IEM, inborn errors of metabolism concept, one gene, one disease. It remains important to recognize the whole clinical spectrum, of course. It is legitimate to describe all the clinical shades of severity coming from one gene, but specifically the Silence classification, and David, know we think like that, it can remain useful as a clinical stenogram, but it has no more role in the nosology. That's not a disease entity, osteogenesis imperfecta type 1 or type 2 or type 3, because the biological basis can be so completely different. So probably we did not do it this time, but in the next time, probably the Silence splitting will go off and we'll go to just osteogenesis imperfecta, cyclophilin B related, or collagen 1 related, and then the clinical part, that will remain to the physicians to define what his or her patients has. The nosology also evolved based on the expansion of the molecular knowledge. And it is no longer so that you have clinically different entities and then you find the genes for them. You have a clinical mass of variability and the genes pop out. That is, you find genes. So it's no longer meaningful to say osteogenesis imperfecta type 1 to type 27. It doesn't help. Just put the gene name next to it, adopt the dyadic naming system, say osteogenesis imperfecta, cyclophilin B related, or CREBP related, or whatever it is. And it's also much easier for the laboratories, and it's much less error prone. So much for the brittle bones. Progress goes on, and the nosology will always be work in progress. We'll always keep on learning new things. The nosology committee thinks that it will remain based for disorders that we don't know molecularly. It will be clinical phenotype, radiography, perhaps biochemistry, but then molecular genetics. No more eponyms, no more funny Greek names that have been useful in the past, perhaps, but have no longer a role today. And I always like to think of the many scientists and researchers who devote their time and energy to laboratory research. They deserve solid evidence. They should not be exposed, excuse me, to the shit of clinicians who want to call this with their names or type 1 or type 2 because they think it's distinct. That's no longer tenable. Take the nosology as a basis, invest time and energy for useful research, not on how you name it, on how you split it. Recently, I got an email from David Salens, from Raymond Dalglish, from Fleur van Dijk, telling me, oh, Andrea, have you seen? There is a new paper and they want to reclassify OI. And they were really disheartened by it. I have omitted the authors there, but that's where we are today. Skeletal disorders are en vogue, and everybody who wants to try can have a go and say, I want to classify Osteogenesis imperfecta. These authors they may be excellent persons, but they have no tradition in studying OI. But still, they come and they want to classify it. Is it really helpful or does it confuse things? Now, my colleagues have written a letter to the editor saying this has no sense, but I'll leave it to you to decide. Anyway, where should we go from here? We expand molecular diagnosis every day and all over the world, also in Asia, in Eastern Europe, in South America, genetic diagnosis is coming. And it is wonderful because it's a more precise prognosis, counseling is better. It's the only approach to develop new therapies if new disorders are recognized. NGS, next generation sequencing, has democratized diagnosis. It had also fragmented diagnosis. When Peter Byers did all the diagnosis for the United States, he learned something from it. Now that the diagnosis is made everywhere, in so many different labs, we may fail to reap the benefits of having so many patients diagnosed. So we need common databases more than ever on the molecular side for the gene variants, benign, pathogenic. We need gene matcher to find individuals or patients with the same gene mutated. We need gene curations databases and more. Welcome to GNOMED, HMG, ClinVar. It's incredibly important. These are really instruments for diagnosis and for research. But we also need gene-based clinical registries, and that's why I completely agree with what Laura Tosi has said about the Danish register. The northern countries in Europe, they are more organized than many others, and having those registries really can help us in discovering connections, natural histories that are extremely precious to counsel patients. We have to document the clinical evolution, what they call the natural history, also for possible clinical trials. Every new medication for a new disorder, the first step is, but we have to know the clinical history before. Otherwise, we cannot prove that the medicament or the molecule is effective. So we have to try and help and build these gene-specific clinical trajectories, call them whatever you want. And I think here, together is better, as in many other things in life. I'd like to close by thanking the Nosology group. You see them here. It was actually the first meeting was in March 22, physically in Lausanne, but it was COVID time, so a part of it was virtual. These people have really invested a lot of time. Just imagine putting together 771 disorders and the 500 genes. It must be very precise. There's certainly mistakes and omissions. So feel free to write us if you find mistakes there. And thank you for your attention. I'll be happy to take questions.